Good morning and everyone. So I will, without delay, I will straight away go to my presentation. So what are the challenges that we are facing currently in treatment of sepsis patients? Day by day we are getting increasing number of multi-drug resistance and extremely drug resistant organisms which are resistant to most of the available antibiotics right now. And with the evolution of modern medicine and modern treatment methods, newer drugs coming up in almost every discipline like cancer therapy, maybe diabetes and all that, not that much new research is being done in the field of antibiotics and treatment of infectious diseases. So we have a lack of newer antibiotics coming up. And the biggest threat is that inappropriate use of antibiotics is again giving rise to the further development of MDR organisms. And WHO has quoted that if things go on like this, by 2050 we will have more deaths due to antimicrobial resistance than deaths due to cancer. So what are the basic mechanisms of antimicrobial resistance in bacteria? There are multiple mechanisms involved. So the most important ones that have been highlighted in green, one is the enzymatic inactivation. The bacteria, they produce different kinds of enzymes which we commonly call beta-lactamases that destroy the beta-lactam antibiotics. Decreased permeability. So the bacteria, they have a cell wall, peptidoglycan layer, and outside that the gram-negative organisms, they have an outer membrane protein. So the antibiotics have to traverse through that layer in order to get inside the cell of the bacteria. So if somehow the bacteria can prevent those antibiotics from entering, then they will definitely be inactive. And alteration of target site. So certain antibiotics bind on the cell wall to specific targets, and after that the specific action is produced. And if by a genetic mechanism that target site gets altered, it gets changed to an abnormal new protein or new molecule, then that antibiotic will no longer work. And the other less commonly encountered sites are the protection of target site or the overproduction of targets, bypassing of inhibited process, and binding of antibiotics. So the important things that you should remember is that the antibiotic resistance can either be intrinsic or it can be acquired. Some bacteria, they have intrinsic resistance to certain antibiotics. So whatever be the other antimicrobial resistance methods existing in that bacteria, the intrinsic resistance is usually not changed. And a single bacteria can have multiple resistance mechanisms. So usually in an antibiotic susceptibility report, you get multiple resistance to multiple antibiotics, and everything cannot be explained by a single mechanism of action. Like a single enzyme cannot be conferring resistance to all the antibiotics. So usually there are multiple mechanisms like enzymatic inactivation and decreased permeability, or enzymatic inactivation along with the efflux pumps. So these are usually occur simultaneously. So this is the molecular mechanisms of antibiotic resistance. So you can see there are the different methods. They involve the different antibiotics in various ways. The enzymatic inactivation is most common. It affects the beta-lactams, aminoglycosides, macrolides, quinolones, etc. The decreased permeability is only seen in gram-negative bacteria, because the gram-negative bacteria, they have an outer membrane protein outside the peptidoglycan layer. So that outer membrane protein is the layer which affects the permeability of antibiotics. So it is not seen in gram-positive bacteria, because the gram-positive bacteria, they don't have that outer membrane protein. And efflux, what is efflux of antibiotics? So once the antibiotics enters the bacteria, they can be pumped out by some channels from inside the bacteria. So if in that, if it happens, again the antibiotics becomes ineffective. So efflux is present in almost against all kinds of antibiotics, and alteration of target site is also seen in against all the antibiotics, and other processes, the other mechanisms, they are less common. So coming to beta-lactamases. Beta-lactamases are enzymes that inactivate the antibiotics by splitting the amide bond of the beta-lactam ring. So the beta-lactam comes from the name comes from the ring that is present in the antibiotic, that is the beta-lactam ring, and that can be destroyed by these enzymes that are produced by the bacteria. So as the bacteria have evolved over time, since first it were identified, and we are constantly treating these bacteria with various antibiotics. Initially we were treating with penicillins, then the bacteria, they found a way of a mechanism to resist the penicillin, so the enzymes also evolved. Then again we tried broader spectrum penicillins, then again the bacteria found a way, a new enzyme to tackle that antibiotics. So as the bacteria have evolved, the beta-lactamases have also evolved over time, and they are now they are now inhibiting more and more antibiotics currently. So the pressure that is, so the main reason why the beta-lactamases have evolved is the only reason is that we are treating them with antibiotics. We are exposing the bacteria to antibiotics, and the beta-lactamases are evolving over time. So they can be transferred, they can be harbored either by chromosomal genes. They are non-transferable. So chromosomes are present inside the bacteria, and it's specific to that bacteria only. So those genes cannot be transferred to other bacteria. But what is more concerned is the transferable genes, that is the plasmids or transposons, integrons. So these genetic elements, they can be transferred from one bacteria to another by conjugation or other methods. So in our body, if there is a single bacteria which has a genetic resistance in the plasmid, so it will share its own plasmid with the other bacteria, and thus the new bacteria will acquire the beta-lactamase genes. So examples are TEM1, SHV type of beta-lactamases. So these names have mostly come from, they don't have any meaning as such, TM, because TM is actually the name of a patient. Timonera. So the patient was in Egypt in the 1940s or 50s. The first beta-lactamase was identified in that patient, and from that name of the patient, this name has been given. So these beta-lactamases can be either like a narrow spectrum or a broad spectrum. So we are not that much worried about the narrow spectrum beta-lactamases, but it's the extended spectrum beta-lactamases that we are more worried about. So they actually hydrolyze monobactams and the broad spectrum cephalosporins. Monobactams is Astronam. So the TM derived beta-lactamases, they are primarily found in E. coli, Klebsiella pneumoniae, but in also other organisms like Enterobacter aerogenes, Morganella, Proteus, and Salmonella. So the majority of tame beta-lactamases, they remain susceptible to clavulanic acid, although there are inhibitors again evolving in this subclass. But the majority, we can remember that they are inhibited by clavulanic acid. The SHV type of beta-lactamases, they are found more in Klebsiella pneumoniae strains. The CTXM or the cefotaxime derived ESBL, they are the most common ESBLs worldwide. So this is the most common ESBL that is our concern right now. They can hydrolyze cefotaxime and ceftriaxone better than ceftazidime. So different ESBLs actually hydrolyze different beta-lactams to a variable extent, and they are inhibited more by tazobactam than by clavulanic acid. And the last one is the oxa-derived beta-lactamases. They specifically hydrolyze oxacillin and the other derivatives very effectively, and they are again poorly inhibited by clavulanic acid, just like CTXM, and they have mainly been described in Pseudomonas, and in which case they confer high level resistance to oxymino beta-lactams. Oxymino beta-lactams are ceftriaxone, cefotaxime, ceftazidime, cefepime. These are all the oxymino beta-lactams. So a close friend of ESBL is AMC. They are very closely related in the sense that the antibiotic susceptibility can be similar and can often be confusing. So these are chromosomal enzymes. ESBLs are mostly plasmid derived, they can be transferable, but MC is mostly chromosomal enzymes. They give resistance to penicillin, narrow spectrum cephalosporins, deoxyminobeta-lactams, and kefamycins. Kefamycins are cefoxitin and cefotetan. And they are not susceptible to beta-lactamase inhibitor. That is the main differentiating point from ESBL. In ESBL, if you add a beta-lactamase inhibitor like cefoperazone sulbactam or piperacillin tazobactam, the organism becomes sensitive. But in case of MC, even if you add this beta-lactamase inhibitor, it will not be susceptible. So these will be resistant to cefoperazone sulbactam and piperacillin tazobactam, these antibiotics, but they remain susceptible to cefepime and aztreonam. This is again another point of differentiation from ESBL. ESBL cannot be treated with cefepime, the 4th generation cephalosporin, but MC producing bacteria, they can be treated with cefepime. And MC production in GNB, gram-negative bacteria, is normally repressed. The transient increase in production can occur in presence of beta-lactam antibiotics. It means that if this bacteria, for example Morgellona or Citrobacter, they have this enzyme in their chromosome, they are not actually producing the enzymes. They have the gene, but they are not producing the enzymes. So the initial susceptibility report will be sensitive to all the antibiotics, all cephalosporins. And once you start treating them with the susceptible antibiotics, they start producing these enzymes from the inside the cell. So during the course of therapy, they become resistant to this susceptible antibiotics. So that thing you have to keep in mind. So in case of serious infections, even if it says that the antibiotic is susceptible, you should avoid these cephalosporins in case of MC producing bacteria. So what are the organisms producing MC? This is a common mnemonic that we use, that is the space. Serratia, Pseudomonas, Proteus, Acinetobacter, Citrobacter, Enterobacter cloacae, and other organisms like Proteus, Morganella, Providentia. So now coming to carbapenemases, we know that this is the biggest threat right now. Like all hospital-acquired infections are almost carbapenem resistant, everything. So these have the largest antibiotic resistance spectrum, and they can hydrolyze the carbapenems, the broad spectrum penicillins, oxyminocephalosporins, and kefamycins, everything. So they are mainly of 3 classes, class A, B, and D. So class A is KPC, that is Klebsiella pneumoniae carbapenemes. It was initially reported from Klebsiella pneumoniae, that is why it's called KPC. It's found worldwide. Worldwide is the most common type, and it's found in multiple gram-negative species like E. coli, Citrobacter, Enterobacter, Pseudomonas, etc. So the class B or the MBL, that is the metallobeta-lactamase. Why is it called MBL or the metallobeta-lactamase? Because it uses the zinc ion for the hydrolysis of the beta-lactam ring, and they are susceptible to iron chelators like EDTA. That's why the EDTA is now currently being tried as a new antibiotic to inhibit the metallobeta-lactamase. And they are resistant to all types of beta-lactamase enzymes, and and except only monobactam, that is it retains sensitivity to aztreonam. And the main types are IMP, VIM, SPM, GIM, SIM, and NDM1. NDM1 has been highlighted because it is the most prominent metallobeta-lactamase in our country. And what we need to know, that the integrons or the genetic elements which harbor the metallobeta-lactamases, they also have other mechanism of resistant genes like ESBL or OXA. So it's usually like a poly mechanism of beta-lactamase harboring bacteria. And the class D, that is the OXA, they can be they are mostly found in Acinetobacter and Pseudomonas. And they have a weaker carbapenemase activity. It's weaker than NDM. They don't have that high emisis. The carbapenems don't have often that high emisis like of the metallobeta-lactamase. But again, similar to metallobeta-lactamase, bacteria which has OXA, it will also have other mechanism of actions, and they can have other ESBLs, or they can have decreased permeability or efflux. So in overall, the ultimate outcome becomes that the the antibiotics are resistant to a large extent. So this is the Ambler classification of beta-lactamase. This is mostly to just classify which ESBL falls in which group and which antibiotics are mostly active against that class. So the metallo-beta-lactamases are present in class A, the carbapenemases are present in class A, B and D. The class C is only consists of cephalosporinases and they don't have carbapenemase. The class C is the consists of the MC metallo-beta-lactamase. So you can go through this is this slide later. It will be, I think it will be available to you. So if we compare the different beta-lactamases like ESBL, MC, carbapenemase, MBL, you can see the ESBL is sensitive to the old beta-lactamase inhibitors like clavulanate, tazobactam, sulbactam. It is also sensitive to cefoxitin or cefotetan. It can be sensitive to cefepime, but is usually not recommended to give cefepime because it can often be resistant. It is obviously sensitive to carbapenems, but is resistant to aztreonam. And the next enzyme, that is the MC, that is the close mimicker of ESBL. It is resistant to all the beta-lactams you can see, but it's sensitive to cefepime. So the cefepime is the main point of difference between ESBL and MC, and also again aztreonam. It can be sensitive to aztreonam also. Carbapenemase, if it is class A and D, it is resistant to everything. And if it is a metallo-beta-lactamase carbapenemase, then it has susceptibility to aztreonam. So pathogens with intrinsic resistance, you also need to keep in mind that some bacteria are intrinsically resistant to certain antibiotics, and you should not use those antibiotics if you are suspecting that organisms. For example, Pseudomonas, it's very important to remember that it has resistance to tigecycline, minocycline, amoxicillin, ertapenem, cotrimoxazole, etc. and lot of cephalosporins are resistant. Enterococci, it's a gram-positive cocci and it has resistance to cephalosporins, then ertapenem, fluoroquinolones, cotrimoxazole. Acinetobacter is again resistant to ertapenem. Serratia is resistant to amoxiclav. Stenotrophomonas is an organism which is inherently resistant to carbapenems. It has a different kind of carbapenemase called L1, L2, L3. These are the carbapenems which specifically hydrolyze carbapenems. So they can be sensitive to cephalosporins, but they are usually resistant to carbapenems. And anaerobes, you can obviously they have specific antibiotics of choice, like aminoglycosides can be used against anaerobic infections. So coming to the laboratory detection of these enzymes, so the basic thing is that if a bacteria has resistance to these oxyminobeta-lactams like cefotaxime, ceftazidime, ceftriaxone, cefepime, and a beta-lactamase inhibitor, usually clavulanate, can block this resistance, then it is called as ESBL. So there are different methods of detection like disk diffusion, broth microdilution techniques, automated systems like BHATTACHARYA, which is now available in almost every lab. So everywhere we are using BHATTACHARYA, but still some old laboratories, they give the susceptibility reports by disk diffusion testing. And then also other methods are double disk test or the E-strip test, and pyrosequencing and microarray technologies. Microarray technologies I think we have discussed, and I will also be showing the report. So what are the main problems in identification of ESBL? So as I already told that it can easily be confused with MC because they are very close. Then ESBLs are heterogeneous, like different subtypes of ESBLs, they hydrolyze different cephalosporins to a variable extent. So not all the cephalosporins may be resistant to every ESBL in bacteria. So some ESBLs are best detected by ceftazidime and others are detected by cefotaxime. And so generally what is said that non-susceptibility to ceftriaxone, if we look at the report, if it is non-susceptible to ceftriaxone with an MIC of more than equal to 2, then it is often used as a proxy for ESBL production. Now coming to detection of carbapenemases. So first, when do you suspect that there is a carbapenemase production? So firstly, the MICs to imipenem and meropenem have to be above the breakpoints, clinical breakpoints that are set by CLSI and UCAST. CLSI is the international body, that's the Central Laboratory Standards Institute. They give the clinical breakpoints against all bacteria and their specific antibiotics. So if the MICs are more than that MIC set point, then you will call it as a carbapenem resistant. Not that it is a carbapenem producing one, but it is a carbapenem resistant bacteria. Why it is so? Because Pseudomonas, Acinetobacter, some bacteria, they can become resistant to carbapenems without having a carbapenems also. And again, some organisms like Serratia, Enterobacter, they can be specifically resistant to carbapenems, but they still retain susceptibility to third generation cephalosporins, that is the lower antibiotics. So once the antibiotic susceptibility report shows that the MIC is more than the clinical breakpoint and it is written as resistant, then the next step would be phenotypic testing. It is usually not done in many labs, phenotypic testing of carbapenems detection. And once the phenotypic testing is done, then we can go for the molecular identification of carbapenems. So what are the phenotypic tests? It is commercially known as, one test is available, it's called the Carba-NP test, where we use double discs of carbapenems or carbapenem discs along with EDTA to see whether carbapenems is being produced or not. So if this test becomes negative, that means the organism is carbapenem resistant, but it is not producing a carbapenems. There are other mechanisms of resistance to carbapenems, like it can be either a porine or it can be also an efflux pump that I have showed earlier. So if the phenotypic test is negative, that which means the organism is not producing a carbapenems, then you do not need to go to the genotypic testing. You do not need to detect whether it's a KPC or OXA or all that. But if it is positive, if it is producing a carbapenems, then we can go to the genotypic testing. So we have the PCR tests and the microarray technologies. So this is the example of the expert Carba-R, which specifically detects the carbapenems. So usually you will get this kind of report, the OXA, IMP, VIM, NDM and KPC. Usually one or multiple of these enzymes can be detected. So in this report, it says that OXA 48 is detected and others have not been detected. And this is another report where it has detected an NDM and others have not been detected. So these two are the most common enzymes that we encountered in our country, either the OXA 48 type or the NDM. And one drawback of this expert Carba-R is that it cannot detect OXA 23. OXA 23 is the main resistance mechanism in Acinetobacter, and we are not detecting that. This is one limitation. And another limitation you can think of, it is not detecting the ESBLs, it is only detecting the carbapenems. For example, in this previous report, this organism has an NDM, but it can also have an ESBL also along with it. It is not detecting that. And this is the microarray, the BioFire film array technique, which is done in many labs. From the lower respiratory tract sample it can be done. It has also similar panels for the blood culture techniques also. So you can see it detects multiple bacteria, not only the hospital acquired bacteria, but also the community acquired bacteria like Streptococcus can be diagnosed. And there are multiple antimicrobial resistant genes, like both it has both the ESBL, the most commonest ESBL, that is the CTXM, the common carbapenems, and also the MEK-A gene, which is present in the Staphylococcus. So this report shows the advantage of the BioFire technique, that is the film array technique, where you are detecting only a single organism and you can direct your treatment against that organism. Now another fallacy of or limitation of this BioFire technique is that you can have multiple organisms detected. Like in this report, we find Acinetobacter as well as Klebsiella pneumoniae. Now, and multiple resistance mechanisms are detected, both CTXM, IMP, NDM, OXA48, VIM, everything is detected. Now, and we don't know, we can't make out from this report that which pathogen is actually causing the infection, whether it's the Acinetobacter or the Klebsiella. And this copies per ml, the 10 to the power 5 which is shown in this report, it actually has nothing to do with the actual colony count or the actual count of the pathogen in the respiratory tract. So this doesn't mean much. It is only the number of copies that have been amplified in the sample. So in this case, we have to target our therapy covering all the organisms that we are getting or according to the clinical scenario, and we have to wait for the culture results which come up, and then we can step down our therapy maybe. So now coming to the management overview of these infections. So what are the options for the ESBL infections? So the IDSA guidelines in 2021, that is the Infectious Disease Society of America guidelines, they say that they have divided the treatment options according to the source of infection. So if it is an uncomplicated cystitis, you can give nitrofurantoin or cotrimoxazole, and alternative treatments are amoxiclav, single dose aminoglycosides or fosfomycin for E. coli, and fluoroquinolones and meropenem, imipenem can be given if other lower antibiotics are not given. Now if it is a pyelonephritis or a complicated tract infection, then we can give either ertapenem or carbapenems, fluoroquinolones or cotrimoxazole again. And if it is an infection outside the urinary tract, then generally the first choice is the carbapenems like meropenem and imipenem. And once the patient is stable, we can step down to other drugs if susceptibility has been demonstrated. So this is for the ESBL infection. So one peculiar thing can you see in this guideline that they have proposed? The major surprising thing is that there are no BL-BLI combinations in this guidelines. That is, the piperacillin tazobactam is missing, entirely missing. Cefoperazone sulbactam is also entirely missing. So either it's fluoroquinolones, nitrofurantoin or cotrimoxazole among the lower group of antibiotics, and among the higher, they have gone straight away to carbapenems. They have omitted entirely the piptaz, magnex that we commonly use in our ICUs and wards. So there is another guideline, the European guidelines. This is the European Society of Clinical Microbiology and Infectious Diseases. They have also come up with their own guidelines, and according to conditions, you can see they are mostly similar to the IDSA guidelines. They say the carbapenems are the drug of choice for bloodstream infection and severe infections, and if it is a bloodstream infection without septic shock, we can use a ertapenem also instead of imipenem. But if if the patient is having septic shock, then you should not be using ertapenem, and only you should be using meropenem or imipenem. But if it's a low risk non-severe infection due to third generation cephalosporin resistant organisms, then they have included piperacillin tazobactam, which was missing in the earlier guidelines of IDSA, or amoxiclav also. And in case of complicated UTI patients, you can use aminoglycosides or fosfomycin. So why is this dilemma or difference due to piperacillin tazobactam for treating ESBL infections? So the cause of this I will coming later. And there are certain other recommendations also given by these bodies. So step down targeted therapy should be done based on the susceptible profile we know. Tigecycline for infections which we commonly use in our ICU, you should keep in mind that it is not recommended for third generation cephalosporin resistant infections. New BL-BLIs should not be used for ESBL due to antimicrobial stewardship, the practices that we usually follow in our ICUs. Cefepime is not recommended for ESBL. And for cefoperazone sulbactam, ampicillin sulbactam, the BL-BLA combinations, there is insufficient evidence to use in ESBL. So what was the reason that I was talking about? This is the trial which was published in 2018, effect of piperacillin tazobactam versus meropenem on the 30-day mortality of patients with E. coli or Klebsiella bloodstream infections and having ceftriaxone resistance. So this was famously known as the Merino trial, and all the guidelines have been changed post this trial. So there was a difference in the treatment approach prior to the Merino trial and after the Merino trial. So what they did in this trial, that they included patients who had at least one positive blood culture. So they only included bloodstream infection patients with E. coli or Klebsiella and who were testing non-susceptible to ceftriaxone. So what is the difference between resistance and non-susceptible is that below the resistance breakpoints there is one susceptible and one non-susceptible or susceptible dose dependent part. There are two subpopulations. So both they had included in the study, both susceptible and non-susceptible, but not the resistant ones. They avoided, excluded. So what were the interventions? The two arms, the patients either received IV piptas 4.5 gram every 6 hourly or meropenem 1 gram thrice daily for a minimum of 4 days or maximum 14 days. The outcome was 30-day mortality. And what was the result? So the result, you can see 12.3% of patients who received piptas met the outcome of mortality. That means they died. 12.3% of patients died after 30 days outcome, after 30 days of treatment, compared to only 3.7% of patients who received meropenem. They died at the end of 30 days. That means the patients who received piperacillin tazobactam were dying more than the patients who received meropenem. So what they concluded in this study is that the findings do not support the use of piperacillin tazobactam among patients with E. coli or Klebsiella pneumoniae bloodstream infection and ceftriaxone resistant. That is the ESBL producing bacteria. In case of ESBL producing bacteria, we should not use piperacillin tazobactam. That is what they said. But is it the entire picture in this trial or in this study? So in 2020, another group of investigators, they did another post hoc analysis. They tried to find out the association between the MIC, the beta-lactamase genes that were producing, and the mortality of the patients. So in the Merino trial, they only said that they only based their study on the antibiotic susceptibility report and the antibiotics that were given. They did not mention, they did not try to find any association between the MIC or the antibiotic genes or the antibiotic resistant genes that were produced. So they in this investigator group, they divided the populations into two parts based on the broth microdilution MICs. One group had a higher MIC to piperacillin tazobactam and another group had a lower MIC to piperacillin tazobactam. So in the original trial, the Merino trial, the method of antibiotic susceptibility reported was not uniform. They had patients recruited from different countries, different labs. So all the labs were performing their susceptibility testing by different mechanisms. So everything was included. But in this post hoc analysis, all the testing, the susceptibility testing or the sensitivity testing was done by broth microdilution only, not by disc diffusion or other e-tests or other tests or other methods. And they also excluded the non-susceptible strains among the piperacillin tazobactam arm. So these two parts they excluded. So and what they found, that after excluding the non-susceptible strains, the 30-day mortality difference was less in the piperacillin tazobactam group than in the Merino trial. And they also detected these ESBL and OXA genes by PCR. They did PCR of the samples and they found out what enzymes they were harboring. They found that it was not only the ESBL, but some organisms were also having the OXA1 genes. And those organisms that had the OXA1 genes along with ESBL, they had the higher risk of mortality. So what they concluded, that the higher rate of non-susceptibility to piperacillin tazobactam was identified by broth microdilution. It means actually the organisms which were said to be sensitive in the Merino trial, some of those organisms were actually found to be non-susceptible. So that means obviously they had to fail. And MIC of more than 16 was related to greater 30-day mortality. That is the non-susceptible population. So if the MIC is lower then 16, and if it is a non-severe infection, then probably we can still use piperacillin tazobactam in this population. So now coming to the carbapenem resistant organisms, they can usually broadly divided into carbapenem resistant enterobacterials, that is the E. coli, Klebsiella, and the non-fermenting pathogens, that is the Acinetobacter pseudomonas. So among the CRE, we have KPC, OXA48, MBL, and non-CP, that is the non-carbapenemase producing. Either it can be a carbapenemase producing or non-carbapenemase producing. So if it is a non-carbapenemase producing, we have the porine channels or the efflux pumps. And among the non-fermenting pathogens, it is mostly similar, except you can see the OXA enzymes are different. So OXA48 is mainly in E. coli, Klebsiella, and 23, 48, 40, 58, these are present in Acinetobacter pseudomonas. And L1, which I said, is present in Stenotrophomonas. So what are the treatment options? Again, the guideline given by IDSA in 2021. So it is again based on the source of infection. It is whether it's a cystitis, uncomplicated cystitis, or a complicated UTI, pyelonephritis, or infections outside the urinary tract, or whether it is sensitive to ertapenem or not. So they mainly base their treatment on the fact that on the finding whether it is sensitive to ertapenem or not. If the organism is resistant to ertapenem but sensitive to meropenem or imipenem, then you can still give meropenem or imipenem drugs, because it is usually a non-carbapenemase producing one. But if it is resistant to both ertapenem and imipenem, meropenem, then you should not you should avoid ertapenem, and you should stick to other carbapenem sparing strategies like ceftazidime, avibactam, etc. The other drugs like meropenem, vaborbactam, imipenem, cilastatin, relibactam, they are not available in India. Cefiderocol is one antibiotic which may become available in the coming years, but still it's not available. So currently our only option for carbapenemase resistant infections is ceftazidime, avibactam. Okay, so one again another peculiarity in this guideline or striking point is that they have almost removed colistin or polymyxins from their guidelines. Okay, so colistin is only there in this part, which is the uncomplicated cystitis part, where colistin can be given only when no other alternative options are available. So this means that they don't have their faith anymore on colistin, and it is only been kept as a last resort antibiotic when other options are not available, because of the toxicity and like uncertainty about the clinical outcomes. And according to the carbapenemases that they are producing, the treatment can also be based on that. That is the result of the expert carba test. Ceftazidime, avibactam works against KPC. Against NDM, that is a metallobeta-lactamase, we have to combine with ceftazidime, avibactam, aztreonam, or also cefiderocol can be given. Tigecycline, we should remember that it is generally given for intra-abdominal infections or complicated soft tissue infections. It is not recommended for pneumonia, UTI, or bloodstream infections. Okay, and for OXA48, like it is again ceftazidime, avibactam. So ICMR, our Indian Council of Medical Research guidelines in 2022, they have also based their treatment regimens according to the enzymes that are being produced by the bacteria. So they have included polymyxins, you can see here, along with ceftazidime, avibactam, and aztreonam. For NDM, they have kept NDM on top because NDM is the most threatening enzyme in our country, our region, in state, wherever. So we have created only this. That why it's called the New Delhi metallobeta-lactamase. It was first identified in New Delhi only because of rampant misuse of antibiotics. So they have prescribed polymyxins, but not for UTI. And polymyxins have to be given not as monotherapy but as a combination therapy with other agent which is again susceptible. And aminoglycosides can mostly be given for uncomplicated infections. And if it is a co-producing enzyme co-producing bacteria like NDM plus OXA40, then it is same as NDM. If it is not an NDM producing, then we do not need the Aztreonam antibiotic. We can give ceftazidime avibactam only. So, does this combination of ceftazidime avibactam and Aztreonam always work? So, this combination of Aztreonam and ceftazidime avibactam provides a viable treatment options, as we know, because usually there is production of metallo-beta-lactamases and other carbaphenamases. So, ceftazidime has no effect in this triple combination. The ceftazidime part does not, we are not needing, we don't need the ceftazidime part, we only need the Aztreonam antibiotic and the avibactam part of this combination. So that's why a new antibiotic is now being produced, or it will be available by the next year, which is the Aztreonam avibactam combination. In that case, we don't need to give these two antibiotics separately, we can only give a single antibiotic. And clinical utility of this combination is limited mostly to the enterobacterials like the Klebsiella in E. coli, and not that much in Pseudomonas and not at all in Acinetobacter. So this combination is not the answer to every drug resistant bacteria. Now currently there are no practical and widely tested methods to assess the efficacy of this combination. Whether this combination works or not, we actually don't know. We have to assume that it works. There are different methods like broth disc elution, disc stacking, strip crossing, etc. Or the susceptibility to this combination can be tested in some laboratories by performing BMD and determining the Aztreonam MIC in presence of a fixed concentration of avibactam. So this was an Indian study who actually tested the synergy of these two drugs, ceftazidime avibactam and Aztreonam, in a institute which has a number of metallo-beta-lactamase producing bacteria. So they found that the highest synergy was seen in the Klebsiella pneumoniae bacteria. However, the synergy was seen in 70% of Pseudomonas aeruginosa and only 29% in E. coli. So contrary to our belief that this combination can work in every drug resistant bacteria or enterobacteriaceae, it may not be the case. As you can see in E. coli, it is not that much susceptible. However, in the cases where NDM was present, most of the isolates did actually show synergy. So coming to the gram-positive bacteria part, in Staphylococcus. So the resistance in Staphylococcus is mainly which is called the staphylococcal cassette chromosome, and it alters the penicillin binding protein, the protein which is present in the peptidoglycan layer where the antibiotics bind. So this is altered and the antibiotic cannot bind to the target anymore. So it is detected if the oxacillin MICs are more than equal to 4, and if it is 2 or less, it is considered susceptible. And another method is the cefoxitin disc diffusion test. It is also both these tests are done together. It is given in the report. The oxacillin MICs are given, and also the cefoxitin screen test is also given. So they are mostly resistant to other cephalosporins also. But one major problem is that even in the presence of MEK-A gene, the phenotypic expression can be heterogeneous, like the gene is present in the bacteria, but it may not be expressed fully. So there can be inside a clone or a group in a clone of bacteria, there can be subpopulations which are resistant and the other subpopulation which is sensitive. So what are the treatment options? So it is different actually, the entirely different between the methicillin susceptible group and the methicillin resistant group. In methicillin susceptible, it's the choices are flucloxacillin, oxacillin, nafcillin or cefazolin, or other antibiotics like clindamycin, doxy, clotrimazole. And in case of methicillin resistant staphylococci, it's vancomycin, teicoplanin, daptomycin, linezolid. Ceftaroline is the new 5th generation cephalosporin which has activity against MRSA. So why is it? So first thing, why I have highlighted these two drugs, flucloxacillin and cefazolin. So one reason is that you won't find these two antibiotics usually in the sensitivity report. They don't have flucloxacillin or cefazolin, but these are actually the drugs of choices. And if the infection is that of a bloodstream infection, then you have to choose between these two antibiotics only. And clindamycin, doxycycline and cotrimazole, they can only be given if it is not a bloodstream infection or like a soft tissue infection like that, then these antibiotics can be given. So in case of a methicillin susceptible staphylococci, you will find actually in the report that it is sensitive to Vanco, it is sensitive to Tico, linezolid, everything, it is sensitive. So most of the clinicians, many clinicians, they tend to give, okay, vancomycin is a very good drug, it is sensitive to this staphylococci, so why not try, why do we need to give cefazolin or anything like that, why can't we give straight away vancomycin, it covers both MSSA and MRSA both, so it will obviously be a better choice. So actually this is not the case, because this was demonstrated very early in a study in 2003. This was a paper which compared nafcillin to vancomycin in case of methicillin susceptible bacteremia. So they actually found out that vancomycin was inferior to nafcillin in case of methicillin susceptible to bacteremia. So even if it is susceptible to vancomycin, you cannot use actually in these patients. Now coming to resistant enterococcus. So enterococcal infections is one of the most difficult to treat infections in our current times. Some time back we could treat it with penicillin, ampicillin or vancomycin with or without an aminoglycoside, but gradually they have evolved the ampicillin resistance. It can be either a penicillinase producing bacteria, which can be overcome by with a combination just like BL-BLI combination ampicillin sulbactam. But if it is a non-penicillinase mechanism, then they have a high resistance to ampicillin and they cannot be overcome with this combination of ampicillin sulbactam, which is particularly seen in E. officium. And if it is a low affinity PBP, it can be seen in E. officium, PBP5 and PBP4 can be seen in E. faecalis, and they are intrinsically resistant to cephalosporins. Aminoglycoside resistance. So generally aminoglycoside is what we should know, that it is not a monotherapy. It cannot be given as a monotherapy for enterococcal infections, but it has a synergistic activity. So if you combine this aminoglycoside with a cell wall active agent like ampicillin or vancomycin, it becomes effective against enterococcal. But for that you have to test the MICs with a higher concentration of aminoglycoside, not the usual concentration that is used in the gram negative infections. A higher level of aminoglycoside concentration is used to test the sensitivity. So if it is so we have to see in the report whether it has a high level and aminoglycoside resistance is there. If it is there, then we cannot use the aminoglycoside for the synergism. Now vancomycin resistance, this is the most difficult and the threatening part. There can be two types of resistance, whether if it's a low level resistance, it is not a major clinical problem, and if it is a high level resistance, it is the most problematic part. It is mostly seen in E. officium, and there are three major phenotypes: Van A, Van B or Van D. In case of Van B, it is resistant to ticoplanin. What you need to remember, the Van A phenotype, it is also resistant to ticoplanin, you cannot use, but it is the most common type. But in case of, if it is a Van B phenotype, it is the second most common phenotype. Usually ticoplanin will be susceptible. So even in vancomycin resistance, you can use ticoplanin. So this is the treatment options for enterococcal infections. I have told, mostly it's a chemotherapy. E. faecalis is a better bacteria to treat because it is less resistant, whereas the vancomycin resistant E. officium is the most difficult antibiotic to treat, and you need to usually use a variation of combinations. So since I have covered mostly my presentation, so I will just summarize what we need to keep in mind things. Phenotypic and both phenotypic and genotypic characterization of beta lactamases, they are important for choosing the appropriate therapy. So the type of method of antibiotic sensitivity testing is important, because in outside labs they generally give a susceptibility report without mentioning what method they have used. So if they are not mentioning the method, how they have tested sensitive or resistant, you have to call the lab and ask that which method have you actually used. And you also need to look at the MIC values, because as we have discussed in the Merino trial and about piperacillin tazobactam, that these values can actually be helpful in determining therapy. And knowledge of intrinsic resistance is also important, because certain antibiotics you have to avoid in case of certain infections. The most two important things is that we need our own clinical data, because most of the guidelines, they are based on the data from the Western world. We don't have our own data. And the most important thing is that we have to treat the patient and not the antibiotic susceptibility report, because that report only means that whatever sample you have sent, a bacteria has grown in that sample, and it doesn't mean that the patient is actually having that infection or not. So you have to treat the patient. Okay, so thank you.
And how to apply those in your clinical practice?
Thank you. One question is, actually we are using Javicept astronum, that is Ceftazidime avibactam astronum for NDM producing bacteria, and books are suggesting that synergistic testing should be done, but we don't do it in our hospitals.
Yeah, most of the labs.
Is it rational? Means what is your point in this?
No, obviously we have to test for synergistic activity, because ICMR guidelines are also now recommending, but it's a bit like tedious to do, because of lack of manpower they most often don't want to do, and they mostly rely on the enzyme testing only. But we actually should do it, like if we have adequate manpower, and then we should do the synergistic testing. And probably if we get in some time in the next year, if we get the astronum avibactam combination, then probably it will be incorporated in the high-tech system, and once it gets incorporated, then it will be easier.
And sir, another thing is that if you give some points on that regarding efficacy index, means in this PDR organisms, when we use that is the MIC by breakpoint value, means to determine the second or third options in the resistance means organisms. So means how, means if you give some points on this, means.
I actually did not get that. Regarding what?
Actually, like, if some organisms is only intermediately sensitive to cholesterol and resistant to all other organisms, means
see,
all
about
bacteria,
cholesterol sensitivity, I skipped that part, because one thing is that cholesterol you will never get as a sensitive report, because the CLSI body they have removed. So in case of cholesterol intermediate, you have to think of it as sensitive. So you can give it if the condition of the patient actually allows you to give. So there are also many other things about cholesterol, and whether it works, how it works, whether you need a combination therapy, or you need whether you can give a monotherapy. So this also, it's a different thing altogether. So everything cannot be covered. But yes, but
means
depends on the.
Give a combination therapy, means the situations is like that. We want to give a combination therapy with polyvaccine, means with polymyxin, like that. Means how you will decide the second or third drugs, means depending on the MIC values. Is there any means guidelines, or is there any tricks we can choose the second or third?
Generally, if you are using ceftazidime avibactam and astronum combination, then it's usually a monotherapy. To treat infections. If it is a very severe infection, or if the patient is not responding that much, then you can use other drugs. Maybe you can choose other groups of drugs as well. Aminoglycosides can sometimes be sensitive. You can use that also. You can use fosfomycin if it is sensitive. It's not only that you have to choose from the drugs which have given resistant or not. You have to ask maybe the lab to give other antibiotics. You have to test for them separately. Site of infection is also important, because a lot of times you will get tigecycline sensitive, but it's the source of infection is a UTI. Then you should avoid tigecycline. So like that. So we can have that chat in the that part in the workshop part, I think.
Okay, so the last questions, and I think it is the questions of everyone. Actually, as our previous speakers, Dr. Shahan has told, actually in day by day we are getting the newer techniques, next generation genomic testings for all those testings to detect the bacteria, their enzymes.
The enzymes.
But we are very much lag behind.
We
always new antibiotics.
Yeah.
Actually, the antibiotics most has been produced before 5 or 10 years, but we are lacking new antibiotics. Means why it is this? Means is there any points? Means
I think
as we have told in next 2050 we all have died because of infections.
Definitely. People
so what is the solutions?
Come to do a surgery and they get infected with we find in our ICU a lot of patients. There is definitely a problem in research work, because the antibiotics they usually are prescribed for a short duration of time.
And after this session we are just going to have 5 minutes break to stretch your arms, and then we'll resume with the next session. Okay.
Yes.